everyone. Welcome. My name is Dr. Laura Sharbash. I am the Chair of Membership for the NJAGD, and welcome to our webinar tonight. It's titled, What's Next? Moving Forward to Establish the New Normal. Thank you so much for joining us tonight. We believe we have an incredible lineup of panelists who will present the latest updates on some very important issues we all face. Those same panelists will remain for a roundtable discussion to answer as many of your questions as possible at the conclusion of the presentation. For this event, the NJAGD is pleased to provide 2 CE hours of credit under subject code 550 for practice management. We do ask that you please enter all questions into the Q&A tab you'll find at the bottom, and our panelists will answer as many questions. Also, please note that we have enabled your mute button for the entirety of the webinar. So without further ado, let's meet our panelists. Joining us tonight, first off, is Dr. Narpat Jain. Dr. Jain is currently in private practice in Tenafly, New Jersey, and he's the president of the NJAGD. He's also a former clinical associate professor at the Rutgers School of Dental Medicine's GPR program. Then we have Dr. Joseph Battaglia. Dr. Battaglia is a dentist in private practice in Wayne, New Jersey. He holds an associate clinical professor faculty appointment in the Department of Restorative Dentistry, Rutgers School of Dental Medicine. He currently is chair of AGD Dental Practice Council, chair of the American Association of Dental Boards East Caucus, and the New Jersey State Board of Dentistry representative to Commission on Dental Competency Assessments House of Delegates. He previously served as chair of AGD Legislation and Governmental Affairs Council, a member of the NJ State Board of Dentistry and president of NJAGD. Dr. Elizabeth Clemente is treasurer of the Academy of General Dentistry. She is currently the chair of the Department of Dentistry at Morristown Medical Center, as well as the director of their general practice residency program. And last but not least, we have Dr. Manuel Cordero. Dr. Cordero is a private practice dentist in Washington Township, New Jersey. He is currently the executive director and the chief executive director for the Hispanic Dental Association. He has previously served as president of the Academy of General Dentistry. Tonight we have moderating the questions during the panel discussion portion is Dr. George Schmidt, who's president-elect of the NJAGD. Dr. Jain, the microphone is yours.
Thank you, Laura. Let me get my screen up here. So today I'm going to be talking about personal protective equipment. This is the hot topic of the day. But before that, I'd like to take a moment of personal privilege and just share with you my experience as the president of the NJAGD. It's been a phenomenal experience working with a great group of people and advocating on behalf of the general dentist. And this time during the COVID crisis has shown the utmost importance of organized dentistry. So I would hope you consider joining us if you aren't already a member, and then also getting more involved with the board if you are a member. We'd love to have your help. So let's talk about personal protective equipment. So what are the concerns with it? Number one concern right now is that we don't have a lot of it available. So we have a lack of availability of PPE. The cost is a major concern. So for something that used to cost 50 cents for an N95 mask is today costing $8, $10 to get access to the same mask. And the second thing is you don't know if it's the real deal or not. The other issue is you're getting different sources of information. You get messaging from the AGD, you get messaging from CDC, OSHA, ADA, the State Board of Dentistry. So sometimes we don't have a clear picture as to what to make of it. Other thing, lack of clear science. There's constantly changing information. So the patients, the team, everybody's concerned about their safety, and that's building a lot of fear, as well as what we're hearing in the media. So how do you manage patient safety? Ultimately, it starts from a hierarchical point of view, and you have to look at, first point, elimination of the physical hazard. So this is what social distancing is doing. This is what the lockdown is doing. It's keeping everybody away from each other, decreasing the risk of transmission. You could do substitution. You could do engineering controls. So for engineering controls, things like staggering a schedule, 30 minutes apart. Things like putting up the sneeze guards, okay? It's things like putting in the suction machines, air filtration. Administrative controls would include things like changing the flow of the practice, having patients waiting in the parking lot before they're being seen. The least effective of all of these controls, believe it or not, is PPE. But this is what people worry about the most. So let's talk about some of the adjunctive controls. First thing I will tell you is I'm a private practitioner like many of you, and my team is nervous. They're worried about their safety. Patients are concerned. However, not all of that concern is grounded in science. And this is why it's important to really approach what we do and how we approach the setting up of our safety based upon science. So let's talk about some of these things. Now, I went out as soon as this COVID thing started happening and bought these over-the-mouth suctions. I will tell you they're not cheap. Each machine on average is about $2,000 a piece. There's no clear directive from any of our governing bodies as to whether these machines are necessary or not necessary. I purchased these machines out of overabundance of caution. And I will tell you this, I really regret making that decision. Why? Because I was looking at doing my presentation and I started looking at the science behind some of this stuff. There's no real efficacy or any reports in the public literature, Medline or PubMed, that shows that these things work. So I spent a considerable sum of money, and for what purpose? I really don't know yet. Was it worth it? Honestly, don't know. Talk about room air filtration. I just saw a post online on NJAGD.com about hygienists requiring room air filtration for treating patients. I understand their concern. As team members, the safety of my team is of utmost importance to me, and I'm sure it is to all of you. We want a safe, comfortable work environment when we're coming in. But requiring an office-wide room air filtration, to me, doesn't make a lot of sense. Again, no science behind it. If you look at historical data of infections, the dental community is at no higher risk than the general population. So we really have to be cautious as we approach some of these decisions that we're making as to what controls we put into our practices. Rubber dam, it's a no-brainer. It's cost-effective, makes the quality of your dentistry better. Rubber dam, strongly recommended. It will decrease aerosols, so that's definitely recommended. Sneeze guards, this is required for administrative areas. It again keeps the distance and decreases the aerosol contact between patients and administrative team members. Pre-procedural rinses. No real, there's a lot of data on bacteria, but not a whole lot on viruses. I couldn't find any information on viral contamination with pre-procedural rinses affecting that. Now, this one I found interesting because I'm a huge fan of Isolite. It's great for isolation when you're doing crown restorations or cementing. However, for aerosol control, the study that's mentioned by Holloman, no difference in aerosol between a saliva ejector and an Isolite. So you might go out there and spend thousands of dollars and spend considerable amount of money per patient, and it's really not any better than using a plain old saliva ejector. So we really have to be cautious as to how much money we're spending on some of these adjunctive controls. So what are the adjunctive controls that we do? So looking at controlling the flow administratively, keeping patients socially distanced. So only one person does checkout at a time, or one person is checking in at a time. You're triaging the patients on the phone, so this way, if somebody is not feeling well, they're not coming into the practice, potentially exposing others. Every patient and staff coming into the practice is temperature screened, and keep a log of it. This way you can document that everybody was well and healthy when they were seen. The key thing is reducing people exposed to aerosols. So you have less staff in an environment. So for example, if you're having an assistant learning along with a more experienced assistant, you may not want to do that right now in this environment. Just keep the one assistant in the room. Having less visitors with the patient. Sometimes a boyfriend may come along with a girlfriend for treatment. They need to wait outside. They can't be in the same room at the same time. Decrease the exposure to aerosols. Parents, that's at the discretion of the healthcare provider. So what's the purpose of PPE? Purpose of PPE is essentially preventing the possible transmission from the dental healthcare provider to the patient, as well as preventing possible transmission from the patient or the environment to the dental healthcare provider. So what is PPE? Masks, gloves, gowns, face shield, goggles, these things. Okay. This is a really important point. It is the legal responsibility of the practice owner to supply the PPE for their staff. The discretion is ultimately of the practice owner and the dentist, because ultimately their liability. They can select the PPE based upon the risk assessment. We're going to get into risk assessment in a few minutes, but that's an important component. Now, let's say an employee says, you know what, you don't have certain thing for me, I want my own PPE. Ultimately, the employer is still responsible for making sure that that PPE functions properly and fits properly. The practice owner is responsible for covering the cost of PPE. Let's talk about risk assessment. This is important. So administrative staff that are doing administrative duties in non-public areas of the facility, and they're away from other staff members. So for example, you have different dividers between different administrative staff, they're at a very low risk. That's important. Next, medium risk. So for example, you're doing an examination for a patient, a crown insert, radiographs. There's no real aerosol associated with these procedures. And so again, the risk classification is medium. Now, if you have a lot of staff working in a smaller facility, that increases the risk level for those staff. What is considered high? All right, so now this is interesting. Infected patients who are and you walk into an infected patient's area in a hospital, for example, that's a high risk. Providing emergency treatment for somebody whose status is unknown or they're a suspected COVID patient, high risk, okay? Now, on a healthy patient, doing aerosol generating procedure is also classified as high risk by OSHA, okay? So this could include things like performing restorative treatment using a high-speed handpiece, ultrasonic scaler, piezo, and even an air-water syringe. Okay. What is very high risk? Aerosols on a COVID patient. So this could be an example of an anesthesiologist intubating a patient or collecting and handling known COVID specimens. So OSHA defines their risk, they define their PPE based upon the risk associated. So PPE in the care of a well patient is different than a suspected or a confirmed COVID patient. They define the recommendations as recommend, not as a requirement. This is so important because this has been a hot topic that certain team members or certain dentists say, I have to have an N95 mask, for example. That's not always the case, because if you look at the true definition of what OSHA is recommending, it's a recommendation. It is not a requirement. The CDC, however, does require an N95 mask when treating a COVID positive patient. That is not the majority of patients being seen in the dental practice. So the alternative options have to be based upon clinical judgment. Liability should always be a concern in the decision-making as to what PPE is being implemented. And if certain language of rules and regulations are not quite clear to you, I would suggest consulting an attorney or your malpractice or workman's comp carriers to decide what's the best way to handle a situation. So how do we manage well, healthy patients with no aerosols? So for example, somebody you're doing a hygiene check on, after the hygienist is done with treatment. So per OSHA guidelines, this would be primarily pre-COVID guidelines. So scrubs, lab coat, gloves, eye protection, face mask. Pretty standard stuff we're all used to doing. Now, that changes though when you're dealing with aerosol. So COVID positive patients, as well as well patients with aerosol in the eyes of OSHA are pretty much the same. So they require gloves. Now notice the gowns is a change compared to before, okay? Before it was okay to just say, okay, scrubs, lab coat, but with the aerosol generating procedure, a gown is recommended. Eye protection, face shields, pretty much same as before. This is where it's, again, different. So the recommendation, not a requirement, is the NIOSH certified disposable N95 mask, okay, or better. Now there's alternatives, let's talk about that. So I learned a new word, by the way, preparing for this presentation. I did not know what the word doffing meant. I actually had to look it up. But so let's talk about donning and doffing. Donning means to put on. So for putting on PPE, it has to be done in a particular order. So the order is as follows. You start with the gown first. You cover the full torso from the neck to the knees, arms to the end of the wrists, and wrap around the back. Fasten the back of the neck and then waist. Next step you put on is your mask or respirator. If you're using a respirator, you must do a seal check. We'll talk about that a little bit later. Next step, put the goggles on, then the gloves. Okay. Doffing means to remove PPE. So the first thing that comes off is the glove. Keep in mind the gloves are contaminated, and you start with the glove, one hand, remove the glove, put your fingers on the inside of the second glove, and then remove it. And it should be disposed of in the waste container in the same room. Next comes off the goggles, okay? Again, keep in mind the outside of the goggle or face shield is contaminated. Remove by the handle, by the headband, and then placed in the designated receptacle for reprocessing or in waste container. Now, looking at the cost of PPE today, as well as the availability of PPE, a lot of us are going to be developing strategies to conserve material. And we're going to touch base on that a little bit as well. Next thing that comes off is the gown. So the gown's front and sleeves are contaminated, so be careful there. Unfasten the ties, pull it away from the neck, turn the gown inside out, and then bundle it and discard it within the same room. That's a key point. You don't want to be walking around your hallways contaminated material. Last step is the respirator. This should be removed outside the room because the front of the mask is contaminated. So you want to grab it from the bottom, the top of the ties, and then remove, and then either discard in a waste container or go over disinfection technique. And the last step is performing hand hygiene. Gowns. So gowns, we have two options. And again, you know, what you decide to do for your own facility is going to be dependent upon judgment and your available resources. In my practice, I'm in the process of implementing reusable gowns. Currently, we have disposable gowns, but going out to try to buy gowns today is very difficult. They're just not readily available, and if they are available, they're available in very limited quantities or very poor quality, which makes you doubt the protective ability of that gown. So if it's reusable, you change it after any aerosol generating procedure. So that means a hygienist who's performing a cleaning at the end of that appointment should be changing her gown or his gown. Then that should be discarded in the same room and then submitted for laundry. If it's a disposable gown, you need to discard it after every patient. Masks. So there's different types of masks out there. You know, N95 is the new hot thing. Prior to COVID, I don't know very many dental practices that actually employed an N95 mask. Let's look at some important details here. So if we look at the N95 mask, you're going to see that the filtration is very, very similar. The filtration is very, very similar between an N95 mask and a level 3 mask. Very similar. They both provide water resistance. So the guidelines that you're going to see from the different organizations is either a level 3 mask or an N95 mask for aerosol generating procedures. There's a study in JAMA released in September of 19 that compared N95 masks to level 3 surgical masks in the influenza model. And the results were essentially the same. They had same level of protection in the influenza model. Now, realizing that the SARS-CoV-2 is different than influenza, however, from a particle size, they're not that much different. So, the results can't quite be extrapolated, but from a safety point of view, I bet the profile is going to be very similar. Now, this gets to be fun. Is this the level of protection we want? I was really I was having a very difficult time finding face shields for my team. So I was lucky enough to find some face shields at a welding shop, and I went on a buying frenzy and bought these Darth Vader helmets. What are the guidelines, the official guidelines, when you don't have an N95 mask available? The answer is a level 3 mask plus a face shield is adequately safe. And for the reasons I explained before in the previous slide, that the level of filtration is comparable between the two masks. Things you could do to improve the seal of a regular surgical mask is to employ something like this. This was a cool gizmo I found. There's a company called Bellis 3D that allows you to do a facial scan using your smartphone. The app will generate an STL file, which you could either send to a laboratory that will 3D print this custom fitted gizmo for you, or you can print it in your own office if you have a 3D printer. So reusing N95 masks is generally not recommended. They're designed to be disposable. However, there is a backup protocol from the CDC that understands that right now there's a shortage. And to address that shortage, they are recommending certain protocols for disinfection. Most hospitals have actually been disinfecting their own masks. Very few are actually getting fresh ones just because of lack of availability. So we're gonna go over some of the techniques that are available to disinfect later. Strategies that are not recommended are, for example, autoclaving, dry heat, isopropyl alcohol, soap, and dry microwave irradiation. They don't work well. One of the strategies that does work is moist heat. The CDC had a recommendation of using the microwave bag similar to use for disinfecting infant feeding equipment. You could also use UV germicidal radiation. It has to be a particular wavelength with a particular exposure time. The risks with this, with the ultraviolet, is if the mask has any folds in it, it may not reach every nook and cranny. The vaporous hydrogen peroxide requires a special machine to do so. So N95 masks do require fit testing. Currently, that requirement has been suspended. However, as time goes on, I would expect that to be reinstated. There's a significant amount of work and time involved in getting fit testing. And right now, due to the lack of availability of various sizes, fit testing is not actually practical. So what is required, however, is a seal test. You have to make sure that there's no leakage around the mask, and that's subjectively done by the person wearing it. Some fit testing resources, and an important resource for you is the AGD return to work guidance. And this is the link for it. So if you go to agd.org/coronavirus, you'll find it. And just some references, and thank you very much. So I will hand the microphone over to Dr. Battaglia.
Thank you, Narpat. I appreciate that. It was an excellent presentation. I'm going to start my presentation, and hopefully we will. All right, coronavirus. Very attractive looking little virus, isn't it? My topic tonight is basically a quick overview of COVID-19 point of care tests. There's been a lot of discussion in the dental community on how and where dental point of care testing should occur. But there are things that we don't know. There are knowns, there are known unknowns, but we can all agree that there are also unknown unknowns, that there are things we do not know, we don't know. And you have to keep that in mind as we go forward. Based on what is known about the virus that causes COVID-19, signs and symptoms may appear at any time from 2 to 14 days after exposure to the virus. Based on preliminary data, the median incubation period is approximately 5 days, but may range from 2 to 14 days. Point-of-care tests are specific and sensitive. Sensitivity is the ability to detect a positive case. Specificity is the ability to determine a negative case. The sensitive test is less likely to provide a false negative result. A specific test is less likely to provide a false positive result. Why point-of-care testing? During this presentation, you're going to be able to evaluate whether or not point-of-care testing is something that you'd like to be involved with. Should such time in the near future, point-of-care testing is available for dental offices. At this point in time, pharmacists have been able to do it through an expansion of the PrEP Act that relieves the pharmacist of liability for their tests that occur during their administration or the obtaining of the specimen. Point-of-care testing is important because you can identify asymptomatic carriers. You may be able to identify well patients. You can identify recovered patients using a symptom-based strategy for treatment. It's an enhancement to your risk assessment, and it will provide data to local and state health departments. If you identify an asymptomatic carrier that tests positive, no treatment, and refer to their physician for further evaluation and follow-up. It is my opinion that no COVID positive or suspected positive patient should be seen in an office setting, but rather referred to an off-site or outpatient site that would allow for the proper PPE and or environmental controls. You can identify asymptomatic well patients and then treat using the CDC recommended precautions. CDC will be introducing interim guidance in the next day, 2 or 3, that will address dental settings and either amplify or revise the present recommendations for dental setting treatment. You can identify recovered patients using the system-based strategy. Again, treat using the CDC recommended precautions. Enhanced risk assessment is critical. We assess risk every day on every patient that we treat. We will determine that risk as we go forward for appropriate levels of PPE and mitigation protocols. Reduce the risk by identifying the absence of pathogen, the presence of pathogen, or antibodies. What's the symptom-based strategy? Symptom-based strategy is what indicates that healthcare workers can return to work if at least 3 days or 72 hours have passed since recovery, defined as resolution of fever without the use of fever-reducing medications and improvement in respiratory symptoms, cough, shortness of breath, and at least 10 days have passed since symptoms first appeared. Now, this study was of 9 patients that attempted to isolate the virus in culture and were not successful beyond day 8 of the illness onset, which correlates with a significant decline of infectivity beyond the first week. So if you have a staff person who is positive or a patient that comes back to work, is it safe to treat? It seems to be, based on this issue right in here, that 3 days have passed since recovery as defined as the resolution of fever, and 10 days have passed since the symptoms first appear. In order to get approval from the FDA for point-of-care testing, the FDA had to issue what they call an emergency use authorization. These tests have not been FDA cleared or approved. The tests have been authorized by the FDA under an emergency use authorization for use by authorized laboratories and patient care settings. These tests are only authorized for the duration of the declaration that circumstances exist justifying the authorization of the emergency use of those tests for the detection and diagnosis of COVID-19 under the section of the appropriate regulatory act. In order to administer those tests, you have to, as a clinical setting, have a certificate identifying your facility to provide laboratory tests. This certificate is issued under the CLIA Laboratory Improvement Amendment of 1988. It establishes quality standards for laboratory testing to ensure the accuracy, reliability, and timeliness of patient results. It requires that any facility examining human specimens for diagnosis, prevention, treatment of a disease, or for assessment of health must register with the Federal Centers for Medicare and Medicaid Services and obtain a CLIA certification. The Centers for CMS regulates all laboratory testing except for research performed on humans. Although all clinical laboratories must be properly certified to receive this Medicare and Medicare payments, CLIA has no direct Medicare or Medicaid program responsibilities. What defines a laboratory or a clinical laboratory? It is a facility for the biological, microbiological, serological, chemical, immunohematological, hematological, biophysical, cytological, pathological, or any other examination of materials derived from the human body for the purpose of providing information for the diagnosis, prevention, or treatment of any disease or impairment of, or the assessment of health of human beings. There are several types of CLIA certifications. Each one is good for 2 years. Certificate of Provider Performed Microscopy, a Certificate of Registration, Certificate of Accreditation, Certificate of Compliance, and a Certificate of Waiver. These areas in this designate the FDA certification or level of required compliance: high, medium, and waived. We're really only interested in the certificate of waiver. Most dental offices could not obtain a certificate of compliance. It would depend on the training of the dentist or the person providing the laboratory services. A waive test is defined by CLIA, a simple test with a low risk for an incorrect result. Presently, you can obtain this information on how to obtain a certificate of waiver through the New Jersey Department of Health Clinical Laboratories Improvement Services. We'll get into a little bit more of the application a little bit later on. Presently, for the purposes of completing an application, you must define the waive test you wish to perform, and that's in section 6. Currently, there are 4 waive tests for the COVID-19, meaning they have been authorized by the FDA under an emergency use authorization to be performed in a laboratory that have received a CLIA certificate of waiver. Here are some websites. I'll leave that on the screen for a few seconds. If anybody wants to take a screenshot with their camera, they can do so. Here are the tests. Sophia, SARS antigen, FIA, ID Now, COVID-19 by Abbott. The fluorescent immunoassay, that's basically what the FIA stands for, is Quindel Company. Ocular, SARS-CoV-V, Mesa Biotech. The Expert Express by Cepheid. Just pointing out that there are no waived FDA emergency use authorization for antibody or serological tests. Molecular test and antibody test. The specimen is obtained with a nasopharyngeal swab. RNA is extracted from the specimen and with reverse transcriptase is converted to DNA. The DNA through a polymerization chain reaction is converted to an immunofluorescent DNA, and those results are interpreted for the presence of the viral RNA. This is not an antigen test. This is a molecular test. An antigen identifies the proteins of the nucleocapsule or other proteins on the surface of the virus, and is a different type of test. It's also immunofluorescent, but again, it's identifying a different part of the virus. Antibody tests, IgA and IgM, basically a blood drawn is taken, finger point blood draw is not as effective or identifiable as vein blood, and the specimen is exposed to the antigen and the results are interpreted. The Sophia SARS antigen FIA test, the small little box, it's the first FDA antigen test. It was authorized May 8th. The letter of authorization download link is provided. Time to results, 15 minutes. Detects the presence of antigen or protein traces of the virus. Is it a fluorescent immunoassay? According to the FDA, detects 80% active COVID-19 infections. Positive rate, 80%. Negative results should be confirmed with a molecular test. Sample type is direct or through virus transmission, transport media. It's taken with a nasal swab or nasopharyngeal swab. Its clear complexity is moderate. However, in patient care settings, it's operative under a clear certificate of waiver. If you wish to purchase it, they're on back order. And if you could try to find them, you could find them on the internet, but the prices have significantly increased. I ordered 2. They told me that the units were out of stock. And then I went back on the internet a couple of days later, and they were listed from $625 up to $2,035. But we can see if we can find them through Cardinal Health, Fisher Healthcare, Henry Schein, or McKesson. Second one, now getting into the molecular testing. The ID now, COVID-19, authorized March 27th. There's the letter of authorization. Molecular, negative results in 13 minutes, positive result in 5. Sample is throat, nasal, nasopharyngeal. Direct test, tested immediately. Do not place in viral transport media as it results in a higher false negative rate. There is some problems with this test as far as the FDA is concerned. Recently, they've had to issue a second instruction for use and because of the high negative result. So they've now said that it needs to be confirmed with high sensitivity, authorized molecular test where the blood is drawn and sent to a lab. The ocular SARS test, again, authorized March 23rd. There's the letter of authorization download link. It again is a reverse transcriptase polymerization chain reaction. Throat swab, nasal swab specimens are combined in this case. Positive result means RNA is present, assumed contagious. Negative result should not be used as the sole basis for patient management decisions. Negative results must be combined with clinical observation, patient history, and epidemiological information. The result is in 30 minutes. All of these tests will have the same disclaimer for negative results. The Cepheid Expert Express. authorized March 20th, their letter of authorization. Test is designed for the Cepheid Gene Expert System. Again, nasopharyngeal, oropharyngeal, nasal or mid-turbinate swab, and/or nasal wash or aspirate. Again, RT-PCR test looking at the nucleic acid. Rapid detection of the current pandemic coronavirus, 30 minutes for positive results, and less than a minute of hands-on time to prepare the sample. Here's the disclaimer again. Negative results should not be used as the sole basis for patient management decisions. Negative results have warnings on every EUA. The negative result does not exclude the possibility of a COVID-19 virus. Negative results must be combined with clinical observations, patient history, and epidemiological information, and should not be used as the sole basis for the treatment or patient management decisions. Some guidance on interpreting COVID-19 results. This is for patients. Anyone who wishes to take that slide, this is from Centers for Disease Control, CMS. Some websites, application. Some websites for each of the units. The fee schedule for a certificate of waiver is $180 for 2 years. Some websites for diagnostics, FAQs on testing. I'll leave these up for just a second or two. The FDA web pages, CDC web pages. Again, we don't know what we don't know. And I leave you with this. As we start to open our practices, now this is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning. So I'd like to thank you all. You have a lot of decisions to make, and you need to look to your legal advice to interpret anything that comes out of the governor's office if you need clarification. So with that, Dr. Clementi, the microphone is yours.
Dr. Clementi?
I'm with you. Sorry. I'm here.
Here we go. Great. Thank
Sorry.
you.
Okay. Sorry, I lost you for some reason or other. I popped out.
No worries.
It says I can't start my video, but you don't need me. Mary, do you have my stuff up? Mary? Mary's not there. Sorry. Mary, is Mary there?
We see you now, and Mary is setting up your
Okay.
presentation.
Yeah, I'm good.
Sorry, Dr. Clemente, a little technical.
I got dropped out right at the.
Sorry, Dr. Clemente.
No worries. Mary's going to start for me, but I have 1 point for everyone who's on the video, who's on taking the course right now. If you have questions, please place your questions in the question and answer box so that we can answer them later if we've missed them. You know, so we want to make sure that we get everything that you need to you. Mary, so I am here to talk about the financial considerations for you moving forward through this really financial crisis for all of us. Mary, you can move to the next one for me. Thank you. So we're going to start with policies for risk management. And this is really, this is a financial issue for all of us as we move forward through this unprecedented event in this country. So these are the sorts of things that you need if you want to manage your risk, which is a financial liability for you. So you need a very firm infection control policy. Some of our previous speakers have given you a great outline for that. And these things need to be in writing, just should you be questioned about what is your policy as you move forward to treat during this crisis. Additionally, you need to be pre-screening patients. So that means when they're making their appointment or the day you're confirming their appointment, that you need to run through the list of questions about their social history and those sorts of things that would be significant to you regarding COVID. Waiting room protocol. I personally have connected chairs. So we've gone through and taped off chairs and put notes on that you will not be able to sit in every other chair. We have, in some instances, we've spoke earlier about calling people up from their car. If you don't have room in your waiting room, perhaps there, and I have many patients that don't have cars, there's a lobby waiting room in the area that I have my office. So all of those things must be addressed in writing so that you have covered yourself sufficiently from risk. Review of the medical history must be really, you need to pay particular attention to this at this point in time. You also need to know about the documentation of where the patient's been, who they've been with. A risk evaluation of the patient themselves. Are they a high-risk patient? Do they have a number of comorbidities that exposure to something could be risky at this point in time? And is the procedure in fact needed? Again, if the procedure is needed, you need to document why. 2 sentences, 1 sentence, it's, you know, extensive decay, pain, whatever it is, it needs to be documented. If those things are not done, you potentially are opening yourself up to a liability. Patients are nervous. People are nervous. You'll find that a number of them do not want to come to your practice right away. They want to wait for things to cool down. So those are the kinds of things you need to be careful about. Is the procedure clinically necessary now? Is it going to cause an imminent problem? Mary, let's move on to finances specifically on the next slide. Since you're not terribly busy right now, this is the time to review your present fees. How long is it since your last fee increase? Just as an example, your vendors, your major vendors for dental equipment and materials have a significant fee increase that's scheduled every 90 days with concurrent small increases that are more able to rapidly respond to the market needs. How long has it been since you've increased your fees or really even looked at your fees? I often say the primary one you need to look at is your initial exam fee, which when you walk into a physician is usually around $300, and very many of us are not even clearly near there. Another thing you can do is list out what you're giving them for their exam fee. You have an oral cancer screening, you have an occlusal exam, you have an exam for caries, you have a perio exam. All of these things, you give hygiene instruction. You also give a toothbrush. All these things are really included in the exam. It's not just a one quick look and you're gone. So the other question with your fee increase is how long since your last review of contracts for your in-network providers? Those contracts have an expiration date, which many of you are not even aware of. Some of them are for 2 years, some of them are a year. I've rarely seen one go 3 years, but I would not be surprised at this point in time if it did. You need to reevaluate those and see what your contract dates are. A review of your business's fixed costs, past and present, because you can then get a sense of, your PPE is, 5 times what it was before. What impact is that having overall on the cost of your business from a monthly, weekly basis? Evaluate your income, therefore, based on that. And you are going to find that many patients are not, again, going to be ready to return to your office. So this makes this much more difficult for you moving forward. review your practice needs. If you're not getting as many patients in, or you're not able to see as many patients, you may want to look at how you need your clinical staff. If you have 2 or 3 people up front because of volume, you may need to rotate those people because you can't necessarily handle the volume under the present restrictions. So you need to do some reevaluation about the flow and how it's going to affect your needs and how it affects your finances. Because if you're not seeing as many patients, can you afford to, or do you need as much clinical staff on a daily basis? You may need them overall, but you may not need them all at the same time. Loss of income evaluation. How much have these last couple of months cost you? What is going to therefore increase your operating costs? Where's your new weekly income needs going to be relative to PPE and supplies, things that you haven't been buying? And for this reason, you need to stay close to what as NARPA reminded us before, is to follow the science. Just don't go out and buy things because people recommend it. Look at your state and federal programs to see if there's still money available or if there are going to be new programs that are available to you. Keep abreast of these things. Mary, let's move on to the documentation for a number of these items. Things to consider are infection control policy, pre-screening questionnaire, a review of your social history for the patients that are coming in. Documentation of patients needs to include necessity for care. So do they just have, they have perio? Are they a diabetic, which would make certain care more necessary than in a healthy patient? Those sorts of things are significant. And you need the patient's consent for treatment to be signed, understanding that there are risks associated with treatment for all patients, but particularly in this time when people may be at a higher risk because of their vulnerability to a virus, which you at some point may or may not know if they have when they enter the room. And while I'm on that, PPE is personal protective equipment. And I saw one of the questions which said, what do we do? Well, when you're treating patients in any facility at any time, in any place, with or without COVID, you must assume that that patient has something that you and your staff do not want to catch. Therefore, we use PPE, personal protective equipment. So at all times, for the entire tenure of my career, I have worn it and assumed that somebody has something I don't want to have. Mary, can we move on to the next one? Thank you. Supplies, I think, I know we were running long on time, so I think I'm going to be able to finish early here, but the group purchasing may be something that you might want to look into. Maybe specialists, a group of specialists in yourself that you refer to as a general dentist, or a group of friends that you have may want to look into buying masks, eyewear, gowns, shields as a group, as opposed to and getting the bargain basement fees as extensive as they are at this point in time for mass purchases versus purchases that you would make as an individual. Another question is, I believe someone else mentioned reusable gowns. Reusable gowns, if you may, when you investigate them, find them to be cheaper, including the cost of perhaps an over-under laundry facility somewhere in your office to cover the cleaning of those, or you can use an outside service to do it. But ultimately, I have found personally that they pay for themselves several times over within a relatively short period of time. More importantly, follow the science. Do not grasp at everything. This is an important time to keep your cash if you can. Things may get more difficult before they get better, and it's very likely going to be the case, because even if we do open up, and when we do open up, there are going to be a number of patients who are not ready to come in yet. So you are going to find that your patient flow is slower regardless of any restrictions. And above all, talk to your peers, because I've gotten some very good advice and some creative ideas from people who've been practicing that I've known for years. So I strongly urge that you follow what they're doing and listen to it. But always, again, go back and follow the science. Do not just jump on the bandwagon. Thank you. And that's it. Thanks.
Good evening. I believe that I am the next one. And I had the pleasure to actually follow 3 phenomenal presentations. I have to say that one of the most important things that I have found during this period of time is the necessity and the importance of good communication and avoiding to follow anything but science, like Dr. Clemente just said at the end of her presentation. It's very important that we look at the sources and that we understand the problem from a scientific point of view, not not as the public is reacting to all the massive information that they're being exposed to. I would like to start my presentation. Let me get this one. All right. One of the things that I brought up was the fact of collaboration, and the Academy of General Dentistry has done something phenomenal from the very beginning, and that is they have reached out to every single specialty organization and other dental organizations to collaborate with and make sure that we help each other in the process of not only educating our members, but managing their how we help them. This coronavirus situation is no exception to it. I had the experience, as you know, Laura mentioned at the beginning of the introduction. I am a past president, actually, of New Jersey AGD, some over 20 years ago. But I'm also the past president of the National AGD. And when I was in that position, I had the opportunity of working and meeting Dr. Tim Ricks, who is this Deputy Surgeon General. And for those of you that don't know it, we have the Surgeon General who's in charge, of course, of the medical part of our government and public health. But we also have the Deputy Surgeon General, which is a dentist, who is the person actually responsible for producing the Surgeon General's report every 10 years. And I did not know that. After meeting Dr. Ricks, after I had invited him to join the AGD House of Delegates session during my presidency, we got to know each other, and I learned that he is a pre-fellow of the AGD. As a matter of fact, he has accomplished all his credit requirements. All he has to do is, like many of us in the academy, all he has to do is take that test so that he can become a fellow of the Academy of General Dentistry. And that made me very proud, and also created a lot of commonality between him and myself. And we also had the opportunity to work and collaborate during the Surgeon General's report task force, of which 170 people participated in, and I was, very, very lucky to be one of them. Now, he, of course, is focused on the public health aspect of it, but he did something, I think, unprecedented, and that is he took the leadership to reach out to myself and another 7 other leaders in dental organizations to see if we could stop all the misinformation going around. And his focus would have been to, first of all, present what is going on around the country to us, to these 8 leaders, and also to 8 representatives of agencies of the government that had to do with health, like the CDC, the FDA, OSHA, and so on and so forth. I actually have a list of them coming up. Interestingly, this came out of a discussion. He reached out to, I'm sure, some of us, and after that discussion, he identified different areas of the government that would be phenomenal to make the information be able to disseminate and also be evaluated by professionals in the area. We have the Centers for the CDC, of course. 3 other members were involved in all the meetings. They even had the Coast Guard, the Health Resources and Services Administration, HRSA. By the way, Dr. Renee Jasko was the only and first dental officer in HRSA when I first met her. And she has done a phenomenal job for us representing dentists. She's also a fellow of the Academy of General Dentistry, which is kind of nice to hear when you have a lot of the top people in our government to be related to our association. We have the Federal Bureau of Prisons. We have the Indian Health Service and the Center for Medicare and Medicaid Services. Pretty comprehensive. And then in the private sector, we had the ADA represented by Dr. Chad Gehania and Dr. Kathy O'Loughlin. We had the NDA, Dr. Sheila Armstrong and Ms. Lavette Henderson, their executive director. In the HDA, they had me as their executive director and Dr. Edwin Del Valle, who's our president. We took turns some of those meetings. Sorry about that. Ms. Ann Bottrell, the Executive Director of the American Dental Hygienists Association. Ms. Robin Ricks, the President of the American Dental Assistants Association. Dr. Connie White, my colleague and friend from the Academy of General Dentistry. And Ms. Michelle Lee, the Executive Director of the Organization for Safety, Asepsis, and Prevention. Ms. Chris Wood, the Executive Director of the Association of State and Territorial Dental Directors. Interestingly enough, we actually increased this group as time went on, and it is the first time, as I understood, that they had the dental assistants and the Dental Hygienists Association at the same level with everybody else, and they were very grateful and appreciative and very involved in the discussions, which I think I found them phenomenal because we are a team. And one of the things that sets us apart from all the other countries in this great globe is the fact that we have a team approach to dentistry. And I think that sets us apart. And having them involved was certainly a good exercise and a good thing to do. We concentrated on providing updates from every single one of those elements that was just presented to you from the FDA. And we also kept an eye on variants. There are all kinds of events, all kinds of false cures, false solutions, false decision-making. And the FDA made sure that they went through a lot of the social media and things that people were discussing and corrected it by presenting it on these websites. By the way, at the end of the presentation, I have all of the websites that have been quoted, not only by myself, but by all the other presenters, are listed because one of the goals of this whole coalition of public and stakeholders is to provide consistent information to the people that need it the most, which is the practitioners. So you're going to see a list of all the sites within the government that is going to provide you about everything you need to deal with the COVID situation during and post. Again, the ADA has been tremendously involved and helpful in providing a lot of the information that they so very well gather. They have Marco Bujic, who's an amazing economist and statistician, and he continues, helping us identifying trends and things that are not obvious to the majority of the population. We also discuss, fake products. We have to be very careful with it. There are two things that really are very, very perplexing, and that is with the PPE situation, I would have appreciated or expected a stronger position prohibiting or stopping the fake and even the ones that are not fake, but the abusive overcharges of the PPE equipment that we need. There is no excuse for this kind of behavior to be tolerated. And unfortunately, this is one, I'm presenting to you one part of the government that I think worked pretty well. And it's because it has good leadership in it and people that are committed to the science of it. But there are other areas of the government. The government, by the way, has, I believe it's 456 agencies. And I only show you here about 8, right? There are 456 agencies, and some of them should be controlling those, the thievery that is going on with the amount of money we have to pay for the masks that are actually real, and for the shields and all the other disinfectants and shields that we need to provide. The ADA continually, by the way, every single one of these stakeholders that I mentioned before, and there were 10 to begin with, 8 to begin with, presented an update during each one of these meetings. We had a total of 5 meetings so far, and we do not know if there are going to be others or not. If it is necessary, we'll continue, and if it is not, we don't have to continue. This is a volunteer and a very spontaneous development of a coalition of government and private, organizations. Importance to know that we are working very, very strongly in with the dental hygienists, even though there has been some discussion as to when. And by the way, I saw that one of the participants in tonight's webinar was asking for some advice as to how to re-enter, into hygiene, in the hygiene practice. And I have to remind you one thing, and that is we have been dealing with infection control for many, many years, and very successfully. I remember in 1983 when I was just getting out of dental school. Guess what? Infection control didn't exist, but I started using gloves, masks, gowns, shields, and actually loops way back when. Why? Because you needed to keep yourself away from the patient, not on top of them. Loops help you with that, and so do the other pieces of equipment that we're using. And if you are doing proper universal precautions in your office, you're already 90% of the way there. And as Dr. Battaglia showed you, I think it was actually Narpat who discussed that at the beginning. If you follow the new recommendations, what you're doing is just increasing to a certain level what we are already doing. It's not that different from what we were doing before, which we're just increasing it with the patients that are known to be coronavirus, positive. But anyway, we have been doing quite a good job as dentists in infection control. We have collaboration. I was talking to you about collaboration. One of the things that we had in our discussion was an office manual from the Canadian Dental Association. Guess what? It's not any better or it's not that different from ours, but it's just showing to you to the extent to which we went for looking for collaboration and sharing it with everybody else that was in the group. The CDC was constantly bringing up health advisory. Today, you probably guys heard something about syndromes in children and all kinds of new development that keep on popping up. The first thing that was clarified was that, you know what, this is not just about old people. There is not old people who are the target. This is affecting all ages. It simply expresses itself differently based on your age group. But it's not that one is more susceptible to be sick than the other. It is again, it's a matter of us continuing to dispel misinformation and make sure that we are following the science behind it. The AGD has been super supportive, and I'll tell you, I'm so proud of our organization. When you guys started at the very beginning of the shutdown to invite any dentist, member or not member, to come onto our webinars and share with us so that everybody's informed and educated and kept up to date. I was so proud of this organization, and I cannot say enough. I think you guys have acted phenomenally. One of the things that was mentioned before was the New Jersey Academy of General Dentistry. And by the way, I'm in many in many websites and in many, discussion groups. I could not believe the level of activity and scrutiny that existed among the members of the New Jersey AGD, because they recheck every fact that was brought up and they question every individual that posted something. And for that, I couldn't admire them more, and I couldn't say more about the leadership. I think they did a wonderful job screening out the misinformation, getting rid of the bad, supplies, and also working together to get some of the stuff themselves, like Dr. Clemente mentioned. Make sure that you can join forces and see how you can do your purchasing the best way. We are discussing grants. Also, we have presented grants in those links that I'm going to be giving. By the way, I sent the links already to Mary, our executive secretary, and they will be available to you for download or on the website. They will determine how to make that accessible to you, but those links were all created for no other reason than to share them with every person that needs them. And I wanted to make sure that you had that. So you will have that at the end of the presentation. And also you will have my information. If you need the information from me, I will be more than glad to send them to you directly. Here are some of the topics that we were discussing, and I'm not going to trouble you. As a matter of fact, there are many of them that are not going to be related to what you're interested in, but you can do your own selection and see what you need. Anything that you need before you open up is in here. All you have to do is spend a little time browsing the list of links, and hopefully you'll be able to come up with some good answers. If you need any other further information from me directly, you can reach me at my email address, as it's in front of you, ceo@hdassoc.org, or my cell number. And as always, and I have always been, I'm here available for your edification. Any way I can help you, please reach out to us. Thank you. The phone goes to you, Laura.
Thank you, Dr. Cordero. Thank you so much. Thank you to all the panelists. That'll go off now. Perfect. So that concludes the lecture portion of our presentation, and off to Dr. Schmidt to moderate the questions for us. Thank you.
Excellent, Laura. Thank you so much. And thank you very much to all our panelists for really a very informative and wonderful discussion there and presentation. And not surprisingly, we have a lot of great questions. So we'll try to get to as many of those as we can. And also we, thankfully, and we're happy to have a lot of staff and auxiliary personnel on the call with us this evening. So we did have a number of questions from them. So let's go ahead and start with that. So Narpat, a lot of the staff had expressed concerns about their safety in the workplace and the workplace environment, and the various things that the rulings and so on and so forth that have come out. Can you just comment or mention a few things about that?
Sure, thank you. Look, their concerns are valid. If you look at what's happening in the media, what they hear about, the number of people getting sick, the number of deaths, it's terrifying. But I want to put a couple of things in perspective. When somebody gets the flu, the media does not put those numbers up every single day. You don't hear, okay, this many people got the flu today, or this many people died of the flu today. I'm not comparing the two diseases, but what I'm comparing is the fear factor introduced in the media. They're not basing a lot of what they're talking about scientifically. Another statistic to keep in mind is you hear that New York City, 22% of the population had antibodies present. You look at the population of New York City, it's 8 million people. You extrapolate that, that's 1.6 million people that have antibodies to the virus. What's the death toll in New York? These are the things that nobody really talks about, but as scientists and as clinicians, we really have to keep these things in mind. Am I concerned for my team's safety? 100%. But I can't fall to the hysteria that's going on in the media. I just think it's inappropriate. I think it's a disservice to our team. It's a disservice to our patients. So
great.
I hope I answered your question.
Great. Thank you, Narpat. And maybe, Beth, I know you work over at the hospital. You've got a very large staff. Do you have anything to add to that?
I think that, Narpat pretty much covered it for me. I've used many of these same infection control procedures, just as a number of us have for years. So, you know, we had N95 masks. We were using 3s on a regular basis. So, because that's always been the science. And again, you know, we sort of grew up with problems one right after the other from infection control. This is just a new one and a different one. So we just have to continue to change and make sure that the science backs up what we're using, because it's not helpful to go out and run after every fire truck because you think there's going to be something going on there. Thanks.
That's great. That's great. Thank you, Beth. And you know, we had a staff member actually write in and say, you know, what's the best way to approach my employer and kind of talk about these things? I do have some concerns, and I want to make sure that my concerns are heard and they're valid. And you know, how do we're all of us on the call here have very busy practices, and what are some of the ways that we would suggest to that person that they could approach their employer and have a discussion about this?
George, may I take that one?
Sure, Narpat.
Thanks. So, you know, in my team, we've had, I can think of 3 Zoom calls over the last several weeks. I want to hear from my staff. I want to hear what their concerns are. I want to address it. I expect them to be open-minded also. I expect them to present me with data if they have a particular viewpoint. I am very concerned about their health and their safety, but it has to be a collaborative effort. And I think, you know, and I'm blessed with a phenomenal team that is willing to work with me and really look at the hard data and say, okay, do we want to do this? Do we not want to do this? And if I give a viewpoint, they're open to listening to me. So I think that's what creates a great team. I have an issue when you know, people are pushing in one direction without any real hard data, and they just want it because out of fear. And I don't think that's a good way to operate. Sorry, Beth, go on.
We actually have a short meeting every morning about where we're going with PPE and what we're using in what case. So for example, if we're seeing someone on an emergent basis and we're not really necessarily doing anything in terms of aerosolization or anything else, a level 3 mask is fine. If we have to, for some reason, do a surgical extraction, then we'll switch to surgical extraction mode, which is the same as it's always been. And we'll use an N95 and greater protection in the room and a number of other things. But if you don't stop and talk about this daily, you have to keep the sort of fear factor under control. So you have to stop and say, wait a minute, we talked about how we're going to deal with this patient that came up from the emergency room that is a potential COVID-IV, potential COVID-19 positive patient. We know what we're supposed to do, so let's do it. And so we need to keep, I think the important part is that you need to keep bringing it back up because people's levels of fear change with ever-changing circumstances in the office. So I think it's important to open communication and do it repeatedly. Thanks.
George, may I also take a stab at that?
Absolutely, Joe. Go right ahead.
Hygienists and our team members are number one concern of everybody because we all want to stay safe and healthy. So I don't want anybody thinking that dentists are really just in it for themselves. Everything has been a team up until now. I don't see things changing. The focus I think we need to look at is basically the risk assessment that we've been talking about. We assess risk with every patient. We need to assess the local disease incidence, the availability and the amount of the adequate PPE to kind of put it in a prioritization. The patient's health, the type of dental treatment that we're going to provide, as well as how the treatment will be administered. And that gives us a better idea of exactly what level of PPE we need. Yes, we treat everybody as they're being infected, but certain people have a higher risk than others. And I think we need to keep that in perspective. We have to follow the science, and we have to be cautious that we don't get a false sense of security because we have a mask that's called an N95 or a KN95 or a level 3. It's how we use. So the risk assessment has to be something that is paramount in everyone's mind. And the communication between the staff and the doctor is paramount. And quite frankly, you need to have a good relationship and feel comfortable being able to discuss this with your employer. It makes a good team and it makes a productive office. And to have anything less than that is just negative for a patient as well as the staff. So you have to reassess your relationship if you can't have that discussion with your employer.
That's great. Thank you, Joe. And Manuel, I saw you were doing some nodding there, and I know that you work with a variety of different people at Hispanic Dental Association, the AGD. Of course, you have your own successful practice. Maybe you'd have a few words to say here.
Well, I could not agree more with Joe and Beth and Narpat. We're a team. I mean, I have never worked in my office with anybody who felt that they couldn't talk to me about their concerns. And the one thing that I do know that I instill in my staff is the fact that we were pioneers in infection control before anybody. I had gloves before anybody in my town wore gloves. When I opened my second office in Vineland, I was the only guy in town wearing gloves and a mask and a gown. And they thought I was from outer space. So my staff has always known that I'm protecting them and the patients at the same time. And I'm myself. The whole idea of a dental environment is that you go there for treatment, not for infection, okay? So we have to make sure that whoever comes in goes out without any further, damage. And I remember the AIDS crisis when it first started. People said, oh, I'm not gonna treat AIDS patients. Guess what? You don't get to know who has AIDS. Nobody knew at the time who had AIDS. You had to treat everybody like they had AIDS. And that's how I did it. By the way, quick incident. So we had a situation before we shut down our office that we were thinking about closing the office on Friday. This is on a Monday. The last patient Monday did not confirm coming in. And I said to my receptionist, please text her and ask why she's not confirming. The patient texted back because she was COVID-19 positive. She had been with us 2 weeks earlier. So we were exposed to her. My hygienist was very concerned, as good as we are, and as much infection control as we practice, she had a right to be concerned and to be nervous because it's normal. It's human nature to be afraid of exposures. And she's also taking care of her two girls at home because the schools are shut down. So there are all kinds of elements that add to the fear factor. And what I did at that moment was, if you do not feel comfortable working until you get tested, you wash your hands and go home. And I will excuse you from the patients. And I did that. And the same thing with my assistant the next day, by the way. If they're not feeling comfortable, I'm making sure that they know they can say that to me and not have any, repercussions, negative repercussions. Because you do have to be concerned about how they feel. You may be doing all the precautionary measures, but that does not take away from their fear factor. We have to respect it. However, let's use science and make decisions based on scientific facts. And that is, we are protecting them in every way possible. And we have proven that by not creating any infections out of dental offices. Now, one of the things that happened with our coalition with the Deputy Surgeon General was in a couple of the incidents, the hygienist and the assistants brought up certain elements in dentistry that were not very concerned about their safety. I don't know how they justified, or whatever they were talking about. But let me tell you something. It is a team concept. And if the team is not treated with respect from every single angle, it's not going to work. But that is not the norm. The norm is what we do in the Academy of General Dentistry. And I don't think that, by the way, I don't think that those are people that are always getting educated like we are, always concerned about their team, unit and their families. They're trying to protect their patients, employees, and family. I think the discussion is good to be had. I'm glad that the person asked about it before in the questions and answer. And the answer is very simple. We'll protect you to our extremes. In other words, you have to be safe and provided the necessary care. And I'm sure that your employer will do that.
Great, thank you so much for that, Manuel. So the K95 or the N95 mask was sort of referenced there. So let's talk a little bit about that. Not surprisingly, we had a lot of questions on that. Narpat, you did an excellent presentation there. Maybe you can comment a little bit on the difference between the K95 and the N95. There's a lot of confusion about that.
Sure, George. So the N95 mask is approved in the US. It's a US certification. K95 masks are either Chinese or Korean. They have not necessarily gone through the same approval process that the other masks have gone through, that the N95 masks have gone through. They're currently approved by the CDC. There's actually a list on the CDC website of the KN95 masks that are currently approved. So I would suggest just checking there.
Great, thank you. And a number of our listeners had had concerns about where they can actually get this. Any insight from any of the panelists here on where you've been able to obtain PPE, or where we see that going in the future?
George, I can take that. Like Narpat said, the N95, that's a one size fits all, and the N95 has different sizes. Presently, the N95 masks allocated through FEMA, and all PPE as well as diagnostic testing apparatus is under the administrative prioritization of FEMA. New Jersey is in Region 2, and that includes New York, New Jersey, Puerto Rico, and the Virgin Islands. So there is availability of N95 masks through FEMA, and they prioritize their distribution. We are number 4 in the prioritization hierarchy, and we should be having availability if Region 2 allocates the supply equitably. It's my understanding that New York is going to be receiving a 2-week supply of N95 masks. I know that New Jersey AGD has reached out to Region 2 Regional Administrator Mr. Von Essen, and I don't think we've had a reply. NARPA may be able to fill you in there. But the availability for N95s is held by FEMA at this point. 3M, which is the national supplier of 395 primarily, Honeywell and a few other manufacturers are doing the same thing. They estimate by July there'll be 150 million N95s available. How they're going to be distributed, however, is the question. The dental suppliers are trying to find their own supply chains, so that's challenging. And I know they are working with FEMA to develop a distribution pipeline to dentists. I know the ADA is trying to coordinate some mechanism as well. So right now we're in a stage of, we have the N95 somewhere. We just have to figure out a way to get them.
Thanks for that, Joe. Hey, Joe, can you also talk a little bit about fit test and seal test? And does somebody have to be trained to administer those? And how does that work?
Okay, the fit test basically is a test that allows the person wearing the mask to apply the mask, don the mask, and then a hood is placed over their head, and a fragrance, whether it be a sweet or a bitter fragrance or some sort of a entity is introduced into the hood to see if the person wearing the mask can smell it. You do some maneuvers, you jump up and down, you read a paragraph, you move your head around, and each time the person who's administering the test adds some of that fragrance into the hood. If you smell it, you need to refit the mask or find a different size. A fit test, that's what a fit test is. Do you need, you can buy the fit test on Amazon, but of course they're all sold out at this point. 3M is the major manufacturer. If you could find them, you can administer them in your office. However, there have been states that have fit test days where the Dental Society or the AGD has a fit test day where people come and get fit tested through So the real seal test, however, is when the mask is placed on and you place your hands on the side of the mask near your face where the mask and the skin come in contact. You breathe in and out. If you can feel any air going in and out, it's not sealed properly. And basically that's it. You can pretty well check YouTube for fit tests and they can run through it. Should you have training, most of the representatives that sell you the masks, especially 3M, will train you.
That's great. Thank you, Joe. We had a number. Go ahead, Dr. Clemente.
I was just going to add to that. We fit test regularly, and you should really not have facial hair that covers the margin where you're wearing the mask. In other words, a beard or a very large mustache. The margin should be clear of facial hair. If you, again, for the seal that Dr. Battaglia was talking about. Thank you.
Excellent, Beth. Thank you so much for that. And so we'll stay with you, Beth. We had a number of questions about paperwork and forms and so on and so forth. And you did mention a few things about that. Thank you for that. But let's talk a little bit about staff. So should we have screening for the staff, and should we keep records of that in terms of a form that should come in and fill out, temperatures and so on and so forth? How do you handle that at the hospital, for instance? And what do you recommend for our listeners?
So every time you go out the front door or any door, and they've cut down to only about 3 exits for this, our temperature is taken. We're asked if we've taken any medications that would lower our temperature before we're allowed entry in the hospital, at which point we stop, we're badged that we were checked, and we have to do our hands. So before we can get into the hospital. So my staff is checked every day, every morning, with a temperature check. We know, as I said, we speak every morning about who in their family, in their personal life, whatever, has someone been diagnosed as positive, all of those sorts of things. So we keep on top of our staff on a regular basis. The reason we ask for documentation is because should something come up and someone says that they caught COVID in our facility, I need to be able to say that we have X, Y, and Z in place and that we have checked and monitored regularly all the way through. And that's the reason for the additional paperwork. As I mentioned, part of your financial, safety is your ability to stay out of a situation where you're liable for something.
Great, thank you, Beth. Sort of as a follow-up to that question, and this is going to go out to the entire panel, there's a lot of concerns about liability, both with the patients and this from our patient staff and others. Any comments in terms of what we feel the liability is there? Manuel, you want to start with that, or?
Yeah, actually, I think we have provided the actual outline of the forms that we have to utilize, and actually the questions and the follow-up for the patients, to fulfill their appointments. In other words, when you're scheduling appointments and when you're bringing patients in, you're going to do a pre-screening, and then when they come in, you're going to do another screening to make sure that we did not miss any misinformation. Once we do that, we have them sign the consent form. They are aware that there's a possibility always of being exposed to an infected individual. And of course, we do our temperature check. We do all the re-questioning again before they bring them in. We make sure they don't contaminate anything in the office whenever they come in. Some people are using hand sanitizers. I'm using plastic gloves. They have to enter with them on. Nobody comes into the office unless they're wearing these gloves. And then when they get out, they throw them out in the trash cans on the way out. Whatever system you're using to maintain, lack of contamination, you do it. But the important thing is that we are taking every step possible. They also have to take some responsibility because they're human beings and they're exposed to it. And we cannot all be, held accountable for anything else that they do. But I don't think that we are really liable for, now, you're worried about your employees. That's why I worry about the most, because they're the ones that you're exposed to all the time. You make sure that they are checked. You make sure that they're protected. And you know what? We've done a good job so far with all the other conditions that we have fought. Have any of you had any of your patients become infected with AIDS or with hepatitis? Have you? Because the truth of the matter is, not really, or at least not that we know of. Otherwise, you know what? I will be telling you right now. So universal precautions to a higher level is going to make us safer and better. I'm not afraid. By the way, 2 questions that were asked about this infection control. One person asked if my assistant goes to, or my employee goes to Puerto Rico and they come back, do they have to be quarantined? Let me tell you something. I'm in Puerto Rico right now because of family health issues, and I have not seen any place more strict than Puerto Rico with infection control. When you come into the airport, they check your temperature. They give you a free test if you want it. And it takes quite a while because of the temperature and the questions that they ask you. And then they give you a little phone number. It says, if you feel that you don't feel comfortable or whatever, and you want to be tested, please call this number. Okay, that's number 1. Number 2, you're only allowed to shop certain number of hours. Everybody has to be home by 7 o'clock. There are strict measures here. And thirdly, guess what? There isn't a severe epidemic going on here. It's under control. It's not as bad as people assume it is. And that's the reason why, because they're very strict. They have been very proactive. Another question that is being asked and everybody worries about, using the Cavitron or the Sonic, the piezo scaler. Well, first of all, if a patient is known to be infected with coronavirus, that's a no, period. Simple and answered no. You do not use anything that creates aerosol with an infected patient. If the patient does not have a health history that is contributory, then you have to use your own judgment. You should always do hand scaling if possible. If the patient has a lot of heavy tartar and there's no reason for you to think they're infected, you know what? I don't see any reason why not. Use the shield that we're providing, use the protective gear that we have, and take care of that patient like you would have taken care of a patient with another condition. I don't think people need to be realistic. This is not going to come and go through the shield and go through the mask and go through the gloves and attack you. That's not what it is. Use common sense, protect yourself, and make sure that you use precaution. You know, check the patient, ask questions. Have you been exposed to anybody? Is there anybody in your family who got sick in the last 3 weeks? Ask questions and protect yourself too. And I hope I answered some of those questions for the staff that is concerned about the infection and exposure to other people coming from Puerto Rico.
Thanks for that, Manuel. Joe, you had done a really nice presentation on testing, and Manuel mentioned testing. So are you suggesting that offices complete the CLIA application?
Good question, George. Right now, under the PrEP Act, which is a act that basically allows pharmacists to administer the test, dentists are not recognized to obtain it. However, and by having the expansion of that act to include dentists, it would definitely enhance their protection and liability issues. So that is one thing we advocate for from a federal level. On a state level, I believe the ADA and the AGD have advocated that the state allow for testing, the point of care testing, because we think that it is within the scope of practice. Some dentists will test for A1C, and saliva samples and other tests. So it really is within the scope of practice. However, until the science really catches up, the molecular tests are very good in identifying positive cases. So I think we'd be able to comfortably identify a patient who is a positive asymptomatic carrier or someone who would be positive. Except the antigen test does only catch about 80%. So people may feel that that is a little too low as far as the positive rate goes. The negative test, however, becomes somewhat problematic because the ideal would be to identify that negative patient, that negative patient would be able to be treated without fear of anybody, because quite honestly, they have no virus that can be contagious. So that would be ideal. But those negative results have a tendency to be a little higher negative than you'd like. In the Abbott ID now and the other testing from the Cepheid seems to be the most reliable. However, if an office wishes to go ahead and start the application, I see no reason why they shouldn't. It's a $180 investment. It's relatively simple. Anybody who wants to, have some information on it, I'm sure AGD will be able to provide that information and guidance. So if they choose to do it, I think that would be something that is a personal choice, as long as it would be in the scope of practice in the, for the New Jersey dentists, or the state that you're practicing in. Your malpractice should cover it. But always check with your malpractice carrier to make sure that what you're doing is covered.
Great, thanks, Joe. Any idea what the cost of some of those testing devices would be, a range?
Well, like I said before, the Sophia 2 by, I can't recall the Quindale company, was a local supplier. It was $635, $250, something like that. I ordered two. I rechecked on the website. It went up to $2,500. So, I'm sure, and they said it was out of stock. I would check with Henry Schein if you're looking for that one. Abbott and any of the other three, I would check with the company directly. I do not know if FEMA is, I don't want to say confiscating, but restricting the allocation to areas or providers of need as they prioritize it. So it may be something going down in the future that would become more available. Like I said in my slide, this is not the end. This is maybe the end of the beginning. We have a long road ahead.
Thanks, Joe. Narpat, I see you're looking to make a comment there.
Thank you, George. So, it's interesting, New York being in the same region as New Jersey in Region 2 in FEMA. New York is getting masks, New Jersey is not. Nothing against New Yorkers, but I say New Jersey deserves their fair share as well. And the NJAGD is working with National AGD to prepare a action alert, which I would like our members and non-members to really partake in and contact our congressional leaders and senators to really put pressure on FEMA to release N95 masks to the New Jersey dental population.
Going back to the test issue, George, I know that the AGD was actually the initiator of that request from the government to allow dentists to do testing in their offices. And as a matter of fact, I received, a copy of the letter when it was first sent out. And I reached out to, as part of a underserved, part of the population that has been more affected than any of the others. By the way, it is the Hispanics, the African Americans, and the American Indians that have been affected the most percentage-wise in this epidemic. I actually reached out to those organizations, and we all three have signed a letter of support of the AGD's initiative of allowing dentists to do testing in their offices so that we can protect the patients, our staff, and the public in general, because the more tests that are done, the more we can isolate this condition. And testing has been proven, as always has been in public health, primary prevention is the best type of treatment. It's the most effective way of dealing with the problem. And it starts with the
And George, if I may, Manny, you're absolutely correct. Well, one thing that we need to find out, we need to be able to identify the patient's test results somehow. We've promulgated the idea that the physician's monitoring program be utilized as a database to collect that information. But we need to find out the infectious or the testing results of the patients that we see. Again, that's something that's off the radar. So when people say, well, how can we tell who's positive, who's negative? At least we could find out when they were tested and the results. But right now we don't have that information.
They should be given a test ID. identifying their
Well,
status.
we won't get into the test track and tracing discussion tonight, man.
Listen, thank you so much, Manuel and Joe. And NARPAD, I know you mentioned this earlier, but Joe, I know you're instrumental at the national level with Dental Practice Council and various other things that you've done. Talk a little bit more about the advocacy that AGD has been doing, and what can we look towards in the future, and then maybe Dr. Jane would comment on that as well.
Well, I would recommend that anybody who's really interested in the advocacy, we've been really on top of most of the things that are important to everyone. The problem is that everything is going through the White House task force, and CDC is having the dental guidance, interim guidance, being released in the next day or two or three, and it's being cleared through the task force at this time. And the same thing with FEMA and PPE and all the supply chains. So it is a purely political discussion as far as the allocation goes. And we are advocating as best we can and trying to ascertain how and who we need to speak with. And we pretty well have everything nailed down. We were able through the ADA as well as the AGD to have dentistry picked up on the priority list. FEMA didn't really understand why we dentists needed PPE. So it's been an educational process for the political class that are making our decisions for us. We provide input when we can. It is a struggle. We need power in numbers. So if you get an action alert, please respond. If you agree with the focus of the action alert, if you have any questions, there's usually a link on there to put your questions in and contact anyone making those requests for you to participate in an action alert. So please understand that we're doing everything we can to make sure that your profession is not only there in the next several years, but will be thriving.
Thank you, Joe. NARPAD, do you want to add anything to that?
No, I think Joe summarized it beautifully. We need our members to be participants in the process to get the maximum advocacy. It is not something that can be just left to the leaders. It has to be a grassroots movement.
Great, thank you, NARPAD. And we're running short on time here, but I do want to address a few of the questions that came in from a financial standpoint. Obviously, we have increased costs, and the timing and so on and so forth may take a lot longer to do a procedure. Some of the folks were asking about whether we should charge a facilities fee and how the D 1999 code would come in. Maybe a little discussion from the panel on that in terms of where you see us going forward with that and how you might be utilizing that in practice currently.
Well, I can say, George, that the AGD Dental Practice Council subcommittee on third-party payers, and we are investigating every possible avenue to address this issue from a financial and third-party payer perspective. PPE, we are in contact with the National Association of Dental Plans and individual insurance providers as we go forward to enter into those discussions. It is difficult. There are antitrust issues that we need to be careful of. So it is not an easy discussion to have. And we urge that everyone look at their financial situation and do a financial analysis and see how this pandemic has affected and will affect their practice going forward.
Thank you, Joe. Thank you. NARPAD, I've got a couple of quick questions, specific questions on PPE, and you had mentioned that. So what about PPE for front desk personnel? Are we recommending that?
Yeah, so front desk personnel should have a level 1 mask, and because they're considered low risk, and there should be a sneeze shield in front at the checkout areas to make sure the admin team is protected.
Excellent. And going back to FEMA, we talked a little bit about FEMA and the possibility of getting some PPE from them or some N95s. Some of the listeners had asked, how is this going to occur? Do we know that? Are they to contact FEMA directly? Is there going to be a distribution point? What's going to happen there?
Good question, George. I don't anticipate there's going to be really a significant number of masks or available. The distribution to the end user is a problem. And should we have the allocation, we may distribute it. Now, we want to find the supply of masks and then worry about how we're going to get it to the dentist. But we may need a third party. There are ways to do it. Pennsylvania did it. So there are ways. It's just a question of developing that the route of distribution.
Great, thanks, Joe. And sticking with the masks, are we advocating a new mask for each patient, even if a face shield is worn?
I'm going to just say, in my personal practice, the answer is no. If we were to do that, we would run out of masks very quickly. And the CDC recognizes that, and they have a protocol on reusage of masks. If you use a level, if you use a level 3 face mask along with a face shield, it is as effective as an N95. So that's what's recommended. Or if you're going to use an N95 mask, there are techniques to reuse it. And there's a link on the CDC website that goes into great detail with that.
Excellent. Thank you, Narpat. Narpat, can you also talk a little bit about potentially fogging the operatory with some of the various chemicals that you heard?
Sure. So they have chemicals specifically designed for fogging, for disinfection. I did get a fogger. I like gadgets, so I've been out there buying all sorts of junk that'll probably end up in the trash heap in a couple of months. But so there's a seminar that's been going online speaking of hypochlorous acid, and so I followed up on that. I did check the CDC website. It is a recognized disinfectant. And I think they spoke about in that presentation at 200 parts per million, if I'm not mistaken, as the effective dose for fogging. How valid is it? I honestly don't know. I did not come across any studies on fogging in my search.
And if I may get in there just for a second on filtration, air filtration. If you're going to buy an air filtration, and you need to have at least a HEPA 13 because the mean particle size of the virus is 0.12 microns. You want something that's going to filter at least 99.95% of the particles out at that level. And you're going to have basically an idea of the airflow, how many times the air in the room is turned over. There's a lot of engineering. Right now, there are some studies that are being conducted for determining how best to do that, a hazardous environment study. And there are other groups that are being consulted. I know the American Industrial Hygiene Association, they're big with environmental controls and filtration and airflow. So at this point in time, I wouldn't rush out and get them, but know that at least must be a HEPA 13. HEPA 14 is a little bit better. With an ionization, with the UVC light may help as well. So wait until the science dictates the best way of doing it. UV lights, I think, depending on the ozone that's produced, I would be reluctant on a UV light. UVC light, probably a little safer. But again, that room has to be closed off. There are environmental issues that you really need to investigate.
Excellent, thank you. Narpat, I know you had your hand up. I know we're running a little bit long here, but we do have a lot of questions. I want to try to address some of these. So
Sure.
Go ahead, Narpat.
So, one of the questions that comes up is the safety of putting chemicals up in aerosolizing these chemicals. There's no long-term data on what happens to you if you inhale this stuff. So, sometimes you have to, as Joe likes to say, you have to be careful what you wish for. If you're using these things, is that going to be worse in the long-term health versus short-term health? So that's a question we really don't know as far as fogging goes.
Excellent, thank you. Yes, Manuel.
I want to go back to a subject that was brought up about the front desk. In one of our meetings, the discussion came up that the front desk people are in fact exposed, and they have had incidents in the New York area. That was brought up by the ADA, by the way. And it is a concern that was discussed quite thoroughly. Nobody thinks that the front desk is exposed. We have some positive cases coming out of New York, and for which I'm changing over from my paper charts to electronic records for that reason, because that is one way of transferring the virus, or just airborne droplets. So I think that they need to have a mask, certainly when they are in the presence of patients, or at least one of those flash guards. Now, another thing that I would really recommend is the decreased interaction between the patients and the front desk, because you can actually change the way you operate so that, number one, things are either prepaid or paid electronically. Number two, the appointments are made in the back room, not in the front room when they're coming out. We're already there with the patients. We have computers, and also, the flow of the patient coming into the office. The front desk is going to be in charge of either helping them come from the parking lot to the actual operatory, because they're recommending that you don't have anybody in the waiting room sharing space unless you have a huge space. So there are things that we need to change, and the front desk is vulnerable. We have to be concerned about that too.
Thank you. Beth, go ahead, Beth.
Speaking about the front desk, actually, we switched over to our front desk wearing scrubs. My rule is that scrubs and shoes worn in the clinic must remain in the clinic. So we launder those scrubs for them, or they must change out, take their scrubs home and launder them separately. So I think that the front desk should be always actually treated as part of your clinical staff, and therefore have the same PPE, the same scrub requirements and everything else. Thanks.
Excellent. Thank you, Beth. And Beth, just we'll stay with you on this one. So what about scheduling? Too soon to bring hygiene back? What's your thoughts on that?
Well, actually, I have had to do some hygiene because I've had some, we handle a lot of cancer patients, and I've had some people held up by radiation. We clean them, and we take alginates, and we provide fluoride trace for them if they're having head and neck radiation. So a hygienist said to me today that prophies are really never emergent. Well, in my case, never say never, because they are emergent, because they can't move forward with their radiation therapy without it. So it's a protocol for clearance. So I think that there's a place obviously there's a place and a time for every prophy. So even if, although we are not using Cavitrons or anything else, we're using just hand scaling.
Great, thank you. Yes, it does. And Beth, just while we have you, can you give us any encouraging news from the hospital in terms of COVID caseload?
Well, actually, the hospital plays a few bars of Here Comes the Sun every time we release a patient, which people all over the building cheer for and everything else. We've been up to some days 50 patients have come out. We have a significantly fewer number overall of COVID patients. We are maintaining the same number of patients from a day-to-day basis, not the same patients, but the same number on ventilators. This disease, once you're on a ventilator, you're generally on for at least 3 weeks, and it's extremely difficult to wean off. It's kind of the good and the bad of putting you on. Maybe saves you, but it maybe is also a problem for you later on. So the numbers have come way down significantly, and we're happy about that. I maintain that the reason the numbers are so high in New Jersey is that everybody is tested 3 or 4 times. So we keep, whereas in other states, you'll notice that there are no numbers, and I think that's because no one's being tested. But it's getting better, and we're starting to do procedures in the OR that have been held off for 2 and 3 months now. So thanks.
That's great, Beth. So we're almost out of time. I just want to ask in closing if if our panel would have any final thoughts in terms of and I'll start with you, Manuel. If the panel has any thoughts on the COVID situation, and maybe reflect back on your experience, you went through the HIV situation, how this compares, and where you see us going forward. And I'm going to ask that of each of the panelists.
Well, I'll tell you, I'm going to bring up a problem that happened early on, and we all disagreed on it. It was actually one of the genesis of this collaboration between government and the organizations, because I actually had a call by the Deputy Surgeon General about the mask issue. He said, "What do you think about this, Manuel?" I said, "Well, I think that dentists are the first line of defense of oral health. And we need to be in line to take care of emergencies, not the emergency rooms, but us." I remember discussing it with NJAGD because some people had turned over their masks. And I said, how can you turn over your mask when we are responsible as dental care providers for oral health emergencies? How are we going to take care of them? And like I said, I went further, discussed it with other people all over the place. And guess what? There are countries that took that approach and ended up having more issues in the emergency room, more contaminations. We, thank God, at one point stopped it. And that's one of the reasons why this collaboration happened, because they said we all have to be doing the same thing and think the same way and do become part of the solution, not part of the problem. And giving up the mask and having FEMA, take over those masks is completely unacceptable. We're healthcare providers and first line of defense ones. We're the only doctors that some people know. And they have no protection when they have no access to us. So we have to start acting what we are and not second-class citizens. The testing issue, we should be allowed to provide that test. Expense or not, that doesn't matter. What matters is that we should be part of the screening process of the patient. We should be doing those blood tests to see who has diabetes. There are so many other things that we have to be involved in for the sake of our patients. Some of these patients don't have primary healthcare providers in medicine. And if they're coming to us for prevention, guess what? Maybe we can spot some problems that can help them out. Things have to change.
Thank you, Manuel. Beth, would you like to take a stab at that?
Microphone.
Just some final thoughts in terms of where you think we're going with this, where we're going to wind up, where we're going to be in a few years with this.
Well, we're going to have some challenges. I think my biggest concern is that we try to protect the practice of dentistry. I'm very concerned that we'll move towards an area where we have to take up facilities someplace else and go in like a physician does into the OR. I think it would be devastating for the practice of dentistry to do that. And the more we sort of fall into some of the traps medicine has had, the worse things are going to be for us. So we need to learn from other people's mistakes and try to not be completely turned around by either public opinion or state mandate or any of those things. So I think that we all have to do the best we can do and keep trying, but be very careful about some of the decisions that we may be asked to make in the future relative to the way we practice dentistry.
Thank you, Beth. JB, any thoughts?
Always. Things will be different for a while, and then how we come out on the other side of this will give us a good idea of our future. But we are in control of a lot of that, and we need to be proactive and not reactive. And we need to understand that we as a profession will thrive as long as we do it as a team. Some of the things that are being promulgated or discussed would definitely hinder all the progress we've made in access to care. Granted, there's a long way to go with it, but it will put us back 10, 15 years. We'll have 2 tiers of dental care, and it's going to be a very significant issue going forward if we can't save teeth with aerosol, and I'll have to take teeth out, put in implants, or take teeth out and you can't have an implant. We don't want to go back to the dentistry of the 50s. We made it through AIDS, we made it through hepatitis, we made it through tuberculosis, we made it through SARS, we made it through MERS. So, this COVID will be another infectious disease added to the list. And my younger colleagues will look back at this like I look back at AIDS and smile at the next pandemic. They will share their stories back in the day like we're sharing ours. So please don't be discouraged. Live with the science, and dentistry will survive and thrive on the other side.
And Narpad, I just want to give you the final word here in the last couple of thoughts, but I do want to personally thank you for your leadership over the past years. I think you've done an amazing job for the New Jersey Academy of Dental Dentistry, as well as the Academy nationally as well. And I know I speak for everybody on the board when I say that. We certainly appreciate everything you've done. And last words from you, Narpad.
Thank you, George. It's really been a privilege. I've enjoyed working with the board, and I really realize the value of organized dentistry. And there's a lot of innuendo. There's a lot of thoughts out there that are put out that don't have a lot of science behind it. And that's the one key point I'd like the audience to take back home today. Let's think logically. Let's work as a team. I agree 100% with Joe. If we work cohesively as a team, look at the data, we're gonna end up with the best results for our teams as well as for our patients. And I think that's super important. So that's my last thoughts.
That's excellent. So let me just go ahead and thank all the panelists this evening for just a wonderful presentation. Really timely information, obviously, and a great benefit to the membership. And I also appreciate your participation in the panel discussion at the end. Thank you, Dr. Sharbash, Laura, for doing all the moderation and announcements there. And on that note, Laura, back to you.
Thank you, George. Hi, guys. I want to again thank everyone. I want to thank all the panelists for such an amazing presentation. You've shed so much light on so much confusion that's going on right now. And I think all the participants can agree to that. So this concludes the Q&A part of the presentation for tonight. You will be receiving your certificates via email within the next couple of weeks. On behalf of the NJAGD, I would like to thank you all for your attendance. We certainly enjoyed having you with us this evening. For those of you that are members, please realize how much we value your support. And for those of you who are not, please consider joining us at the NJAGD. Keeping in mind, like we've said, we are stronger together. So we'd love to have you. If you have any questions about membership, or if we can assist you in any way going forward, please contact Mary Eastwood, our executive director, and I'll put her information up right at the end of this. We'd like to remind you to join us on Friday, May 29th for our annual meeting. We have Gigi Meineke, who's presenting her webinar entitled Jawlines, Just When You Thought You Understood the Mandibular Border. Thank you, stay safe, and have a wonderful evening. Let me get up that information here for you. Here you go. Just in case you need Mary Eastwood, you can find us on Facebook. We have a COVID page, NJAGD COVID-19, that you can join. And on Instagram, there's the return to work guidance. If you need to jot that website down, I'll leave that up. And that's our CE next Friday the 29th. Hope to see you guys there. Have a good night.